Good evening, and thank you for attending AACP's webinar with Dr. Jane Brewer presenting Aligning Perspectives, the Role of Upper Cervical Chiropractic Care in Craniofacial Pain Management. I'm Shaylin, the Association Manager for the AACP, and I will be the host of the webinar tonight. The webinar is approximately 50 minutes, followed by a 10-minute Q&A session. Please enter any questions you have in the Q&A box at the bottom of your Zoom screen, and we will address them at the end of the presentation. The AACP has no conflicts of interest. Registrants can expect to receive a recording of this presentation via email within 10 to 14 business days, and AACP members attending live will receive their CE certificate of attendance within 30 days of the webinar air date. I would like to mention some upcoming events for the AACP. You can register today for the Live Foundations Mini Symposium course on June 8th in Fort Worth, Texas, and gain invaluable insights and skills to enhance your practice and improve patient outcomes. AACP's next complimentary webinar will be on June 12th with Mike Cantrell and James Anderson presenting Looking Beyond Breath and into Integration, Compression, and Grounding. Also, be sure to mark your calendars for AACP's 39th Annual Symposium at the University of Notre Dame on October 25th and 26th. I would like to introduce our speaker tonight, Dr. Jane Brewer. Dr. Brewer is a renowned upper cervical chiropractic specialist with a distinguished achievement as one of only 60 professionals worldwide to hold a diplomate in chiropractic craniocervical junction procedures. In 2015, she opened Precision Chiropractic in Northern Colorado with the vision of caring for people suffering with some of the most complex neurologically based issues like migraines, vertigo, and dizziness. Her goal is to work with patients on creating a long-lasting solution by restoring the integrity of the spine and nervous system to address these issues at the root. When she's not in the office and doesn't have her head in a research journal, she loves playing outside on her mountain bike, skis, on her own 2 feet with her husband, Wes. They have 2 very dog-like cats, always drink good coffee, and enjoy sharing quality time with friends and family. And with that, I would like to turn it over to Dr. Brewer.
Thanks so much for the intro, Shay. And I know that diplomate in chiropractic craniocervical junction procedures, that's a mouthful.
Oh, that's a tricky one.
All right, it's really good to be with everybody this evening. Thank you so much for attending. Over the next hour or so, we are going to just do a lot of exploration as far as how the upper neck is related to the craniofacial region. And hopefully we're just going to learn together and learn how to identify certain things in the upper neck so that we can really better the outcomes for our patients. I have no conflict of interest. I don't have any financial disclosure or otherwise with the information shared here. These are learning objectives that were shared, and we're just going to go through all of this together so that we can know better how to care for the folks that are seeking us out. I always like to start out by talking about why I do what I do. Like Shay said in our intro, we take care of a lot of folks that wouldn't necessarily be considered traditional chiropractic patients. I'm going to just read a little bit from these testimonials from folks that I've cared for throughout the years. Things in the craniofacial pain world, like occipital and trigeminal neuralgias. This particular individual had MS for over half of her life. She developed occipital and trigeminal neuralgias, had a surgical intervention, and then developed some complications after that. She sought me out, as many patients do, often as a last result. If I had a nickel for every time I heard somebody say, I've tried everything before they land themselves in my conference room, I might have a pile of nickels. But she did tremendously well. Her pain improved dramatically. But the things I love the most about these cases are what you see at the bottom here. And it's really about quality of life, right? This person came in, she couldn't wear a hat, sunglasses. When the wind blew, it was excruciatingly painful when it touched her face. but now she's driving and she can enjoy being outdoors. She can wear a hat and sunglasses now. Things that seem little to all of us, that's a big deal for that person. This person had blinding migraines since the age of 10. I couldn't even imagine that. We did our thing, did our analysis, and he's been migraine free for almost a year and a half with no medication. These are the stories that inspire me and keep me going, as I'm sure you all have as well in your clinics. And I'm also doing these things because I'm a firm believer that the whole is greater than the sum of its parts. We have a shared responsibility. There's a lot of overlap with what we all do, and I think that we are better together, and we're going to dive into some of that. We're going to talk a lot about the CCJ, or the craniocervical junction. That's my area of expertise. That's where I live. We're going to talk a lot about the atlas, which is that top vertebra in the neck. It was a Greek titan in mythology, and it is responsible for holding up the weight of our world. To introduce myself, my name is Jane, and these are some of the things that I love doing. A lot of these things are actually what brought me into chiropractic, like skiing and mountain biking. Those are my two kitties, and I'm also really involved in the community. I like to use my business as a platform to do good in the community and stay involved with just a lot of connections. I'm the owner of Precision Chiropractic. We're located in the Fort Collins, Colorado area, about an hour north of Denver. And I've been in practice almost a decade this year, which is kind of difficult to believe. And I am a graduate of the Diplomate in Chiropractic Craniocervical Junction Procedures, or the DCCJP. There's about 60 of us in the world. We have started a fourth cohort for that program. And I really just want to start out by talking about the many things that live under this umbrella. And we're really going to narrow our focus down because there are a lot of things that live under this umbrella. Many of my colleagues who practice chiropractic, they do wonderful work with patients. They're trying to introduce more joint mobility, recouple motion using joint cavitation and manipulation. That's not what we're going to be talking about here today. We're really going to focus in on the upper neck. We use image guided techniques for really finding a better neutral for that very delicate, very specific area. It is a very complicated area, and in my opinion, it really requires a dedicated approach to management. There is an International Chiropractic Association, and underneath the International Chiropractic Association, there is a council on upper cervical care. And so I'm here today as both a board member and a representative of that council. I am also newly elected board member of the Society of Chiropractic Orthospinaology, which is the technique organization that I'm a part of. And the council has a number of jobs. It houses the Diplomate program. It is just interested in also teaching other chiropractors about our specific training in our area of specialty. We connect with the public on these issues, and we are also very interested in professional collaboration. So I'm here as a representative of those things. And this list should look familiar to everybody, because I would venture to guess that many of these symptoms are presenting to our offices each and every day. This was the definition of craniocervical syndrome that was put forth in this publication, and I see these symptoms come through my door every single day, which wouldn't necessarily be considered, a traditional chiropractic candidate. But as we go further down, hopefully this all makes sense. I know without a shadow of a doubt that it's all connected. As we watch this DMX study of the jaw opening and closing, I'm going to try to play that again. I just want you to watch the movement of the neck and see how much, just with the simple opening and closing of the jaw, how much that neck moved, particularly at the top. When I saw that, it was pretty astounding, because we typically don't think of the top teeth as very mobile, but they're connected to our head. And what I want to start by doing is just considering some of the factors that an upper cervical chiropractor like myself looks at when we're doing an evaluation of the patient. And we're going to start at the very beginning, all the way back to the embryology. And so ossification of these areas, so the formation of the structures that form these areas, start very early on in embryologic development. The flat bones are formed by the intramembranous ossification, the vertebra formed by that endochondral ossification. And The last joint to really ossify is that sphenobasilar synchondrosis in the second decade of life. That's going to come back later. So put a little earmark there. The atlas has 3 primary ossification centers. All those primary ossification centers happen inside the womb. Secondary will happen outside the womb. And all of this is not heterogeneous in nature. You know, you may see some young children, if you treat young children who have different stages. Of course, you're probably looking at imaging that would show this. The axis below, so C0, C1, C2 is typically considered the 3 structural pieces of the craniocervical junction. Axis has 7 total ossification centers, 5 primary and 2 secondary that develop outside the womb. The last part to fuse is the tip of the dens there. Shifting into some of the soft tissues that we really consider and evaluate, we have the suboccipital muscles, which when you start to understand a little bit more about them, these are not muscles of movement. And what I mean by that is they're really sense organs. So these muscles are incredibly dense in muscle spindles. And so functionally, the muscle spindles are stretch detectors. They are looking at how fast a muscle is either lengthening or shortening, as opposed to the Golgi tendon organ, which, you know, when you're lifting weights, those Golgi tendon organs are telling how much tension that muscle is exerting while lifting, for example. So the suboccipital muscles have no Golgi tendon organs. That points us in the direction of really understanding that these muscles are really sensing joint position. And when you compare the density of muscle spindles in the suboccipitals, which are pretty high, to some of the muscles of mastication, like the pterygoids for the movement of the jaw, the medial pterygoid has none. And so it starts to get a little interesting when we look at the role of these muscles really as proprioceptors or sensors as opposed to muscles of movement. So that's really important to understand. We also have the static stabilizers. So this area, the craniocervical junction, we make a big sacrifice in this area. We sacrifice stability in favor of mobility. So this is just some of the layers of ligamentous tissue that support the upper neck. And they have a pretty remarkable tensile strength, especially that transverse ligament that acts like a seatbelt that goes across the odontoid process of the dens to ensure that there is no movement of the dens that could possibly impact the neural tissues there. Interestingly, the dentate ligaments, and I have a really keen interest in understanding the dentate ligaments. It's a really unique ligament, and it's very relevant, I think, to craniofacial pain syndromes or presentations. These are actually extensions of the pia mater. They anchor the spinal cord within the central canal. They're fixed laterally on the edges to the dura mater that line the canal. And the first pair of these dentate ligaments sits really high up. They actually extend upward into the foramen magnum, and they're thickest and strongest at their most superior position. And they're arranged kind of horizontally at the atlantoaxial facets. And these dentate ligaments, because of where they attach, you can see in that bottom picture there that they can create that transverse stretch or tension on the spinal cord, affecting those lateral columns, mainly the spinocerebellar tract and the spinothalamic tract, which has a huge influence on pain, temperature perception. And these tracts also lie in close proximity to the spinal tract of the trigeminal nerve, which we'll talk about a lot later because it's a huge player, of course, as you know, in the development of a lot of craniofacial pain disorders. There's been a lot of really cool recent research as well about the myodural bridges. So these are actually muscular tissue that have direct attachments to the dura mater. So when you think about the generation of pain, when you have these muscles that attach directly to the dura in between the atlas and axis, they kind of sneak in that very narrow space and attach to the dura. When there is either instability or misalignment at the craniocervical junction, then it can have a huge influence on the neural function and create a huge choke point in that area. these are also things that we think about, as far as the influences of what a misalignment can do. We have the circulation of cerebrospinal fluid, so the hydrodynamics that are associated there. So the majority of the CSF produced by those ependymal cells in the choroid plexus, about 500 milliliters produced daily, and approximately 150 milliliters circulating at any given time. And it was, in early days originally thought that fluid was there to cushion the brain against any forces. But now, as we start to understand more about CSF and the glymphatic system, there really is a huge role to play there in the clearance of metabolic wastes, ridding of those abnormal tau and beta amyloid proteins that are implicated in a lot of neurodegenerative conditions. We also, of course, when we have a choke point for that normal fluid dynamic there, it can lead to increased intracranial pressure, leading to things, of course, like migraines and headaches. We have the dural venous sinus system, the anterior and posterior blood flow through the circle of Willis. I have nightmares sometimes looking at this picture because of how much we had to study and memorize all of the distributions in school. This picture really illustrates, though, the relationship of everything we just talked about to the position of the structures of the craniocervical junction. So as we look here from inferior to superior, so caudally to cranially, you can really see the position of the carotid sheath and that neurovascular bundle there. And it's not difficult to imagine that a malposition here could have potentially a pretty significant influence on these three things. And these three things are going to continue to come up over and over again. So of course we have the nerve pathways, and we have blood flow going north into the head, south draining out, and the circulation of cerebrospinal fluid. And so it's just so important to realize how many critical factors are really densely packed into what's really a small area. All of the cranial nerves, these, of course, are all the sensory and pain generating nerves to the face. We have the muscles of mastication and tongue movement, postural control of the head and the neck, eye movements. Of course, we're going to make a special nod here to the trigeminal nerve that has both the sensory and motor components. That's going to keep coming back over and over. So let's put some of these pieces together. I think why this matters is these people are both looking for us as far as care is concerned, and they're also looking to us for answers that likely nobody else has been able to provide. And we love to collaborate with other providers here. And I've been fortunate over the last decade to make really valuable connections with other providers. There's kind of a short list at the bottom of a lot of these other professions and modalities that I have personally co-managed patients with. I'm sure I'm missing a few on this list, but it really does take a village. And what I want to make sure that we are hopefully all on the same page on is that none of these structures or tissues live in a vacuum. You can't influence any one of these things without having a ripple effect on the other. I love this. This is a Newton's cradle. I actually have one of these behind me in the conference room. Whenever there's a kid in here, I know it because that thing is ticking and I can hear it all over the office. I invested last year in a cone beam CT. So at the beginning of January of 2023, I invested in 3D technology, which really, I think, is the future of imaging in the upper cervical realm. This is the very first cone beam CT image I took. And this gentleman came in, he's early 30s, had crippling migraines several times a week. And structurally, from my perspective, it's really easy to see why that could be the case. These misalignments can happen.
All right, I'm going to try to show you guys
hear
this.
the audio
see here this patient's atlas, and as we scroll down,
we're looking here at the
slices,
rotation of the atlas and the
you
counter
can start to
rotation of
see how
C2.
dramatically C2 is
And hopefully
rotated
you
over to
can
that
see
right
that
side.
on the bottom left corner
That's pretty
there.
significant. I think this guy has some
We've
neural
got
tension.
the atlas
If I thicken this
shifting.
up,
I'm going to use my little tool
like
here.
so,
We've got the atlas
you can
shifting one
really
way
start to
and C2 shifting
appreciate
the
the
other. And these misalignments
counter
can happen
rotation
and have
that's
a
there.
huge impact.
Big time.
Just again, another visual that trigeminal nerve, those tracks really do extend into, beyond the CCJ, into the lower cervical spine below C2. And when we look at the impact that can have when we start to touch on these craniofacial pain conditions. So, of course, we have migraine that I think many of us are seeing and treating in our offices. We've got that overload to the trigeminal system. We've got the sound, the smell, the light coming in, and that creates a huge influx of information that creates the phonophobia. Couple that with inadequate venous drainage, and we have what could be a significant migraine episode for some people. We can look at the rotation of the atlas, which we just saw in that video there. I like this simplified illustration because it does show the placement of some of these important vessels and structures. And we've got those structures that sit really just anterior to the transverse process of the atlas. And in those transverse foramen, in those opening on the sides of the atlas there, we have the vertebral arteries. And that, of course, is what provides blood flow to the posterior 20% of the brain or so. And just anterior there, we have the internal carotid artery, the vagus nerve, and the internal jugular vein, which is that main drainage pathway. And so again, not difficult to see how any shift of the atlas can start to impinge on those structures. I keep using the word choke point, and I think that's one of the most accurate ways to describe it. Michael Flanagan did this study and really started to look at hydrodynamics of cerebrospinal fluid and the clearance of those metabolic waste products from those tissues. And I just think that's a field of research that's going to be interesting as we push forward and pioneer to look at that. We also have the cerebellum that sits in the posterior fossa there. And sometimes we can have those low-lying cerebellar tonsils that can also crowd the foramen magnum. So for any of you who are ordering MRIs, viewing MRI in your practice, this is one thing that I encourage you to look at. And I think traditionally we're taught to look at this from a sagittal view. And contrary to what we may have learned, especially in our education, we are taught to look at that from the sagittal view, but truly that's not the best way to view these low-lying cerebellar tonsils. So when we look on the left here at the axial slice, you can see the cord in the middle, and then you can see here the crowding at the foramen magnum from those low-lying tonsils. And you got to think too, what is that doing as far as almost putting a cork in that bottle for cerebrospinal fluid flow and the increase of intracranial pressure, which can, of course, be the generator of a lot of craniofacial pain issues. And then when we look at the coronal slice here, we see these little, the tonsils there of the cerebellum really drooping down and causing a lot of crowding for the flow of cerebrospinal fluid, as well as, of course, neural function. And so that's something I encourage you to look at and look for if you are ordering MRI. And a side note to that, most of the MRIs that I receive from patients when I request their records, of course, are done in either imaging center or hospital setting. And those images are generally taken supine, of course. One thing I think that's just really interesting to start looking at, I know in my area, about an hour south of here, we have an upright MRI facility that when I order MRI for people that I suspect have either low-lying cerebellar tonsils, Chiari malformation, any craniocervical instability that would affect the ligaments there, I always order those images upright because typically these folks' symptoms are more pronounced when they are in an upright position. And so I think it's important, if we are able to image the patient in the position that generates the most symptoms, because I think it's going to give us more valuable information. So now as we start to shift into looking kind of at the jaw, there's a lot of information here. We don't have time to get into all of the nuances of this particular slide. All of that to say that the relationship between the head, the neck, the mandible is quite complex. It's driven by a lot of proprioceptive input from the trigeminal system. And the one thing I think that upper cervical chiropractors can add to this picture is giving people who work in the dental landscape a consistent and reproducible position for the upper teeth to live in so that the lower teeth can then be fit to them correctly. And so I can't see everybody. I'm going to have to trust the audience participation here, but just take a second and I want everybody to move their bottom teeth. And it could look something like that. You know, you can move the jaw in all directions. That's what makes the TMJ so remarkable. It's its ability to hinge, open and close, glide back and forth. And now I want everybody to take a second and move their upper teeth. And I can't see what you all are doing, but when I think about moving my upper teeth, when you move your upper teeth, you have to move your entire head. And so we don't typically think of the upper teeth as movable, but they are movable. They're moving all the time, and they're moving with the movement of our head. And so when we start to look at all of this, I get myself into this whole chicken and the egg roundabout conversation with myself. And I did a pretty thorough dive into the literature, which I enjoy doing. And, you know, it's kind of like looking for anything on the internet. You could find what you're looking for. But there's a lot of literature out there to support the effect of the jaw on the position of the head and the neck. And then the opposite, of course, is true. There's a lot of literature out there to support that the position of the head and the neck also has a huge influence on the resting position of the jaw, particularly, of course, at the craniocervical junction. And so there's a lot of little snippets here. There was a really interesting study that I read, and maybe some of you have read it as well, where they used rats and they fixed the dental crown to see what would happen to the alignment of the spine. So there's a lot of interesting connections between that malocclusion and the development of scoliosis or abnormal curvatures in the spine, you know, the occlusal contact variation with changes in head position. And then we start to realize as well, as we move the jaw, like we saw in that initial video, that has a huge influence on the position of the neck. This was a study done by a colleague of mine, Dr. Jeff Schulten, who practices in Calgary, Alberta, Canada, and Dr. Westerson. They used the T-scan occlusal analysis system to look at occlusion, both before and after the adjustment. And this is what they found. Sometimes it gets better after the adjustment, but sometimes it gets worse. And that is, in my opinion, exactly why we need each other, because it is the chicken and the egg. Sometimes we need to get the neck position right so that we can get the jaw to behave and create those nice occlusal contacts. And sometimes the dentist is step one, and then we get the head better positioned over top of the neck. But either way, both of those things need to happen to achieve optimal patient outcomes there. So we're just going to start to flow into things that hopefully, as you look at your own images in your own clinics, as you're caring for your patients, I would hopefully like to teach you some things that I measure that help influence my care for my patients, that you can start to measure too if you're not already doing so. So I want to look at some of these measurements. The first is going to be McRae's line. So we're looking at basilar invagination, and that is when the tip of the dens, so the top of the odontoid process of C2, starts to migrate upward and starts to potentially impact the neural tissues that are coming through as they exit from the foramen magnum. So the normal position of the tip of the dens, when you measure from the basion, so that very tip of the clivus, and the opistheon, the tip of the occiput there, the dent should not sit any higher than 5 millimeters below this line. If it starts to creep up, like you can see in this upper picture here, that's really starting to encroach on the exit of the medulla, and which of course transitions below to the spinal cord. And so it really is about understanding what lives in that space that we can't see, and what's happening as we start to take away from that space. Chamberlain's line is a modification of McRae's, the basion-opistheon line, when maybe those structures aren't very easily visible on the imaging, just looking at it from a bit of a different perspective. And again, some, the upper picture there on the right-hand side starts to look a little suspicious for basilar invagination, and this would be representative of something that looks a bit more normal. The clivoaxial angle, I think this is one of the most important things that should be looked at when it comes to understanding what's happening as far as how the head is positioned over top of the neck. So the clivoaxial angle is a measurement of the lower part of the clivus and the back of C2. And the average range should be between about 150 to 165. This varies in the literature from source to source, but that is a pretty normal accepted range. As we start to get more acute, so as that angle starts to narrow, you can start to imagine how, as the dens comes back, it can start to create some ventral compression there. I have the little circle of Willis there because I think it's also important to remember that that circle of Willis lives at that sphenobasilar synchondrosis. And it really is the first curve, that the first bend that spinal cord needs to take as it exits from the skull and travels down into the spinal canal. And as we move the head and the neck, the neural axis is designed to stretch approximately 10% of its length. But if we have that acute clivoaxial angle, it is really going to start to create a lot more tension on those neural tissues than is acceptable. And so that's something we need to look at. Grab Oaks is also another measurement that can be indicative of some issues there. We're measuring the distance between basically the front of the spinal canal to see how much clearance is there. And we want to see at least 9 millimeters of clearance there to ensure that that medulla has the space to descend. And some things that can influence this, we can have laxity of that transverse ligament. We can see that after severe injury, or, there's also genetic considerations. Connective tissue disorders such as EDS or Down syndrome can tend to have ligamentous laxity. So these are things that we often look for and analyze for. And we can have also structural components to this. We can have retroflexion or a kind of a bulbous tip of the odontoid that would create a larger measurement here too. So when it comes to why this even matters, again, we just go back to this laundry list of symptoms. And this, I look at this kind of like a sliding scale, right? And there's a lot of areas of gray that can happen. And this is what we have called in the past cervicomedullary syndrome. And that is when these influences have an impact on the neurology, on the blood flow, and on the cerebrospinal fluid. So those three things that keep kind of coming up over and over again. All right, so now that we've gone through a lot of these nerdy things, I'm just going to talk a little bit more practically about the things in day-to-day practice that I look for and analyze for before it even makes sense to adjust a patient. So how do we determine if somebody that comes into one of our offices is even a candidate for care? So we do a lot of analysis. And some of the diagnostic indicators we look at on the left there, we look at sensory integration and balance, limits of stability, cervical challenge, weight distribution. We can measure balance with a single leg test. We use these calipers to look at overall posture and pelvic tilt. We can use grip strength to start to see if there's impingement on the nerves that branch off from the neck that travel down the arm into the hand. Like I said, we use cone beam CT in our office. We also have digital X-ray that I used for many, many years, of course, before we upgraded to the 3D technology. We select very specific vectors of adjusting, which I'll show you a bit more of for anybody who's not familiar with some of these upper cervical adjusting methods. And we deliver a very tailored, very gentle adjustment, either by hand or by instrument, depending on the chosen technique. I pulled a little bit of information from some research about some of the assessments that you can expect upper cervical chiropractors to use. Of course, we rely a lot on palpation. We're looking for tender muscles, muscular spasm, restrictions in range of motion. Some will palpate for an inflamed or tender C2 dorsal root ganglia. We look at a functional leg length inequality. Some will use infrared thermography to assess for differences in capillary blood flow from left to right side. Postural analysis, and of course, imaging is key when it comes to understanding person to person what type of adjustment is needed and potentially what type of adjustment is not needed. We also use neck care technology. We look at joint position error. We test range of motion. We look at motor control of the neck. That's really cool new technology that some colleagues of mine are just starting to employ in practice. And this is, I'm going to just sort of talk through, this is a very abbreviated and sped up version of an analysis that I do on a cone beam CT to get to what I arrive at, what I like to think of as the GPS coordinates I need to adjust a patient. So I measure for head tilt. We look at C1 rotation with respect to how the skull is sitting on top of the head. I'm going to try to talk with the video. So we look at the center point of the dens, and we look at C2 rotation with respect to the atlas and the skull. We look at the lower neck as well, which we call the lower angle. We look to see, and you could see if the spine is, of course, tilted over to the left side, and we measure that to understand how we would need to create a correction vector for it. We look at what we call the condylar circle. So we look at the circle of the occipital condyles and the circle formed by the upper axial surface, because the atlas really sits as a wedge in between the skull and C2. And we look at the tilt of the atlas at the superior and inferior margins of the lateral masses there. And what I then do is kind of create a visual representation of that misalignment. And what you'll see on the next slide there, as I'm done marking, is I kind of put together a sheet that outlines all of this. And I think this is one of the coolest things about what makes us different, is that what we do, again, going back to underneath that chiropractic umbrella, we're really here to create a neutral position for that patient, whatever that looks like, for the head to sit on top of the spine in a much more centered fashion. And the numbers that you see there on the left are all the measurements that are taken on every single scan that I take. The center picture, which looks like an earlobe, it's because it is, we're able to mark the tip of that transverse process, which is where the stylus of the instrument is then placed. And then the bottom table there are all the vectors that I need to make the perfect correction for that particular individual. That looks different for every single person I care for. I've been doing this for a decade, and I will likely never see two that are just alike. This is what an adjustment looks like. A patient's kiddo took this video, so it might be a little bit shaky. But using those vectors, what I did was just measure that out on the patient. On top of the instrument there is an angle measurement. So I'm setting the angle of the instrument for this patient. Everything is guided by laser. The stylus of the instrument is just really gently placed over that transverse process contact. And then I think at the most, this instrument that looks kind of intimidating delivers about 2 pounds of force. So it is incredibly gentle. It's probably on the realm or the spectrum of chiropractic adjustments, one of the most underwhelming things a patient can possibly experience. But what isn't seen is what I just showed you, which is all the work that goes in on the back end to tailor that for that person. And so all it really takes is that gentle tap to start to guide things back towards a better place. This is an example of pre and post imaging. In some techniques, mine included, we always make sure that we got the correction that we're looking for. And so on the left there, you can see that yellow horizontal line shows that tilted atlas that was not sitting straight. And then after that correction, we can really see that the head is sitting better and what we would call more orthogonally positioned over top of the neck. And this looks like a small thing. And I guess when you measure it out in millimeters, it is technically quite a small thing. But for these folks who are suffering from the ill effects of having these misalignments, of course, the implications on those neural pathways, blood flow, cerebrospinal fluid flow. I've had comments where, folks will sit up and the tension, the muscular tension in the neck will just melt away. Their muscles will be much more supple. I've had some patients describe it as almost like pulling the drain plug out of a plugged up bathtub as that fluid dynamic is returned. It really makes a huge difference as far as how these folks feel. And, feeling better is terrific. But to me, again, I really look at the restoration of quality of life. And sometimes these are people who, going back to the beginning, like can't put a pair of glasses on, or just can't drive because they're not sure if they're going to be hit with a blinding migraine episode. And that's the rewarding part, I think, about what any of us do is providing what intervention is necessary for that person so that we can help them along the way of living a better quality of life. I really looked at this talk as aligning perspectives. Hopefully, I've given some helpful information to you all to start looking for in your clinical practice, especially some of the more image-guided radiometrics that you can start looking at to see, is there a layer there that might benefit from seeing or being evaluated by somebody in your community who is trained in these procedures. Just because we don't know about these things doesn't mean we're not influencing them. And that's why I will always continue to be a lifelong learner when it comes to learning more about the realm that I live in, but also branching out and learning from other complementary professions, because I think that we are really all looking at the same thing, just from a different lens. And the more we can build bridges and collaborate with each other, the better off our patient outcomes will be. And I think with knowledge comes responsibility. And I think we all have a responsibility once we know better to do better. And we all have difficult cases or failed cases. And I really think that a lot of those are a result of either being unaware or unable to control these certain variables. And I think if we can understand and isolate these variables and create the circumstances as best as possible to control them with the resources available to us, the better off we're going to be. And I always love this quote: "A mind stretched to a new dimension never returns to its original form." And I think, again, it just goes back to knowing better, doing better. And it's not for us, it's really for the folks that entrust us with their care. Thank you so much for allowing me to be a little part of your evening tonight. I've included some resources here if you're looking for a DCCJP or a diplomate in chiropractic craniocervical junction procedures. There is the website with a listing. As I mentioned, we do have a fourth cohort that is going through this program, so we hope to grow in number. That is my personal email, and just a few links on social if you have questions or want to get hold of me. I'm an open book. If I certainly don't have all the answers, I'm humbled to have been asked to talk. There are people who know a lot more than I do. And if I don't know the answer, I will certainly do my best to either find it for you or connect you with somebody who does. So I guess with that said, I would love to either field any questions or discuss anything further if anyone has them.
Awesome. Thank you so much, Dr. Brewer. A question that came in is, many of us have CBCT in our practices, so this is awesome to see how you're using it. How do you position your patient in the ICAT?
Great question. And so I think the beauty of cone beam CT, when I was using X-ray, there were very small tolerances as to what how much rotation was acceptable in an X-ray, which would then kind of trigger a retake, right? If a patient was sitting crooked, I couldn't do a proper analysis. But the beauty of cone beam is that we can kind of take out the rotation in the software. And so I try to keep the patient in as much of their neutral head posture as possible. That starts to create a bit of a tricky situation when we have somebody with a lot of forward head posture, but I don't use the chin piece. The patient is seated, and I try to preserve as much of that neutral posture as possible, or neutral for that patient, because I really want to see that misalignment as it sits.
How can we find someone like you near us? Which I think is just a really great question. They mentioned NUCCA.
NUCCA, yes. And so that directory that I have listed on this last slide here, that would be a great place to start. And NUCCA is one of the techniques under the upper cervical umbrella. So, I practice orthosphinology. There's NUCCA, there's Blair, Atlas orthogonal, Epic. There's a number of named techniques underneath the upper cervical umbrella. I would venture to guess that most of those technique organizations, such as the NUCCA organization, also holds a list or a directory of doctors who are members or certified in that technique. Or please use my email. Feel free to reach out to me. I'm always happy to provide a personal referral to somebody. We're a small group of people, so if we don't know each other personally, we at least know of each other. So I'm happy to quarterback that as well.
Thank you. A myofunctional therapist is asking, can you please comment on how mouth breathing causes the rotation of the atlas?
Gosh, I feel like that could be its own presentation in of itself. There's so much connection between airway patency and, of course, head and neck position. And that's kind of a cycle that drives itself. So, the head comes forward because we need to breathe. And, that is driven by a lot of other mechanisms, CO2, chemical balance. I don't know that breathing through the mouth would necessarily cause a structural misalignment. Maybe this is just the perspective I look at things through as an upper cervical chiropractor, but I would think potentially the misalignment could be the driver of disordered breathing. But surely those two things, again, it's got to also be a two-way street.
And what is the optimal distance from the anterior atlas to the posterior border of the ramus?
I don't know. I don't know if there is, our anatomy is all different. And I think that's what is the beautiful thing about what we do. And that's also what poses a lot of challenges to what we do, is that everyone's normal. And of course, there's going to be a range of what is considered normal, but everyone's normal is going to be a little bit different. So as far as the like a millimeter or centimeter measurement between the anterior atlas to the posterior border of the ramus, that is something I would have to look up, and I'm happy to dig a little bit. Oh, good. And you'll email me your finding. Thank you. I appreciate that. That's a curious thing that I would like to look at. Thank you.
All right. Awesome. What is the mechanism for environmental allergies disappearing after C1, C2 becomes stabilized?
So, there's so many connections, the neuroimmunoendocrine systems, and how that's mediated. There's a lot of layers to that. And, these are the more intangible things, so to speak, that can benefit with upper cervical chiropractic, right? And, these are some of the mechanisms that are driven by that neuroendocrine immune cycle, and how all of those, all of the immune components that will become reactive to environmental allergies can stand a chance of regulating better when we have better communication over those neural pathways. That's a pretty deep and wonderful question that I'm happy to chat a little bit more about offline.
Awesome. Well, thank you so much again for the wonderful presentation and for being here tonight. Again, everyone will receive this recording within 10 to 14 business days, and the CE certificate of attendance for AACP members attending live will be sent out within 30 business days.